welcome on behalf of the Commission. I'm Gillian Boehm, the Chief Advisor, Quality and Safety at the Commission, and welcome you all very, very warmly to this symposium. We, of course, would much have preferred to have had the symposium in person, which we have had in previous years, but circumstances, as you all know, will not allow that at this time. We also have a full registration, and we're really impressed and grateful for that, knowing how clinical care services are really under pressure during the ongoing waves with Omicron from the pandemic. So our very warmest welcome. I also have apologies from Dr. Janice Wilson, the Chief Executive of the Commission. She's unable to be with us today, but thanks you and wishes you all well for what is an exciting program that we are going to have. Our first speaker today is Steve McCrone. Steve is a much sought after facilitator and speaker, and I can personally attest to that as we've used him to help in our education and training at the Commission. It's very good. Steve has had much experience in bomb disposal in the New Zealand Army, and this gave him a good understanding of decision making under conditions of uncertainty. Recognising this and that traditional management theory is of limited use in fast changing and highly complex environments, AGLX Health, Steve has dedicated his career to learning and applying the complexity theory principles into his consulting practice. Steve has developed the AGLX adaptive strategy approach, and he is an accredited Carnarvon trainer. I'm sure Steve will introduce himself and tell us a little bit more about him and about some of these strategies and workshops that he's been doing. A very warm welcome to you, Steve. We so look forward to your presentation. Over to you. Thank you.
Kia ora koutou katoa, ko Stephen McCrone, toka ingoa. Thank you, Gillian and Jane, for the opportunity to speak today. It's a shame it can't be in person. I'm going to firstly say hello to my mother and my wife, both of whom are on this call, both of whom are medical professionals. So, hello. I'm gonna just have a sort of a brief kind of talk today. I'm going to draw some pictures on the whiteboard. So if you can't see, maybe you could if you pin me on your screen, then you'll be able to see when I start drawing, and you'll also be able to observe the broad range of facial expressions that I use while I'm talking. Okay, so the talk today is the unintended consequences of improvement. And I've been working in not so much the health sector, but it's certainly in safety and quality improvement for quite a number of years. And I've been working with Dave Snowden, who's developed the Carnarvon framework. And I know Dave has been in New Zealand on a number of occasions and spoken in respect to his work in what we're starting to call anthro-complexity, so complex systems as experienced by human beings, sufficiently different from the sort of mathematical complexity that you might get if you look at, say, the Santa Fe Institute, or biological complexity of ants and termites, if you get into that. So anthro-complexity is an emerging kind of field of study, and really speaks to this idea of how humans experience complex systems, given that we have intelligence, intention, and multiple kind of sense of identity. So that's really where I'm coming from in this. The key really message to the health, safety and quality community is actually, from my perspective, like right now, here in 2022, is the time to really push the reset button in terms of how we think about our interventions in the health system. Incremental improvement and getting better at what we already do are no longer, in my view, sufficient to accommodate the complexity and the rate of change that we're seeing in that system. So I'm going to be quite provocative in my description of both where we're at and perhaps where we need to be. And I'm hoping that that's going to elicit some interesting questions and some interesting feedback. I've always been of the view that, like agreeing with me is not a prerequisite for success. And that really comes from my time arranging large-scale demolitions, where I used to say to my guys, if one of us makes a mistake, we're all going to suffer the consequences. So we can't assume that any one of us is right. We have to think for ourselves. We have to ask questions. We have to challenge each other. And oftentimes you might see in the military, rank and seniority sometimes interfere with that. So we have to kind of let go of that in order to learn and in order to remain safe. And that's a sort of a theme that I'm going to bring through today. So can I just maybe get in the chat if you want to sort of either raise your hand or just type a note. For those of you that are familiar with complexity and Cynefin and the work that Dave Snowden's done, and I know there'll be a number of you and some of you haven't. It's not a prerequisite for anything we're going to teach today. I'm just quite interested. I've been working with Dave and a sort of international community of complexity specialists for about 15 years now. Last year, the 21st anniversary of Cynefin, we as a community wrote a book called Cynefin, Weaving Sense Making into the Fabric of Our World. And a lot of what we talk about in that book is a number of sort of aspects to complexity that are arranged there. So Cynefin looks like this. Okay, and I'm not going to spend a lot of time on it. It's spelled C-Y-N-E-F-I-N. The benefit of Google, you can probably learn more about it in 5 minutes than I could teach you. And we talk about different types of systems. So some of the systems that we have are ordered and they are clear to complicated. We can think of those as maybe linear systems or systems where we can have a known or knowable outcome. We have complex systems and we have chaos. Try and stay out of there, although it is available to us, particularly in the health sector. And in the middle, we have confusion, which again is a legitimate place to be. And a good example of that is as New Zealand a couple of years ago entered into a COVID constrained world, then we were locked into confusion about how long is it going to be, what are we going to do, what's the right way forward. And it is a legitimate place to be from a systems perspective. So those are the types of systems: ordered systems, complex systems, chaos systems we talk about today. And my first point is health system is inherently complex. And I know a lot of you guys already know this. This is not me decoding the Enigma machine. You can feel it when you interact with the system, the inherent complexity. You don't always know what you're going to get. The system doesn't have the consistency and repeatability and the equilibrium that we might see in the ordered systems. Okay, there are parts of it that are clear, parts of it that are ordered, but by and large, the way that we have multiple agents interacting to give rise to often surprising effects and results means that it's complex. And we have this in the health system, this thing we call nested complexity. So at a cellular level, I am a complex organism. At a physiological level, I'm a complex arrangement of cells. At an interactive level, if I go and see my GP or I go and seek treatment for a condition, that will be a complex interaction. No two patients are the same. No two people will respond the same way to the same treatment. At a systemic level, there is nothing, in my view, or no organization more complex than, say, a large public hospital. Multiple agents interacting in a way that gives effect to this, the outcomes and the outputs that we want. And then at a systemic level, the health sector is a very, very complex system. And, a challenge, for a lot of people is they try and define what the health sector is. The McDonald's at the end of Point Chevalier, where I happen to be, is as much as part of the health system as my daughter's circus skills program that she does is, my wife's role in Auckland DHB is all part of the health system. They all can interact to give effect to, say, my personal health and well-being. So that's the first point, is the health system is inherently complex. And there's three things that are interesting about complex systems. I mean, there's a lot of stuff that goes on. You could study this stuff, and I do kind of geek out on it. Is firstly, they are non-linear, which actually means that they can react in surprising ways. Small things can have big consequences, and sometimes big things can have no consequence at all. Okay, so this non-linear system means that they don't respond well to linear methods that work in the ordered systems, such as root cause analysis. In a complex system, there's no one cause, or oftentimes no one cause for the result, the output, or the impact that we see. And we, as humans, love to sort of simplify things so we can tell one story that acts as a kind of a sense of agency across the system in terms of how we caused this thing to happen, or how other people caused this thing to happen, or agents in the system caused it to happen. Oftentimes that's not true. They don't respond to things like the 5 whys, for instance. So we can see that sometimes we can bring our techniques from complicated across to complex, and they kind of don't work. The system doesn't seem to work like that. The second point is they are deeply entangled, which means that they're interconnected at a level that often we cannot detect. Okay, the system can't be pulled apart and the components understood in a way that gives you a view to how the whole system will operate. Yeah, I mean, a really kind of a silly example is you could anesthetize and dissect a patient. You will never find their sense of humor. Okay, which brings me to the third point, is this idea of emergence. The sense of humor is an emergent property of you as a person and the social conditions with which you're in. You might be the funniest person at the party, but if you tried the same thing at a funeral, it might not be so funny. So we have this idea of context. We have contextually appropriate actions. Okay, so we have this idea of emergence, of system properties that are neither predicted or planned. The system just moves in that direction, and we can see that through things like culture. You might have 2 levels of a hospital or 2 parts of an organization that are ostensibly do the same thing. I do a bit of work with retail banks. So you say, there might be 3 or 4 retail banks that ostensibly do the same things in the same way, but they have the emergence of quite different cultures, quite different sort of look and feel. Okay, and the systems can sometimes be quite surprising in that sense. And those 3 things together, non-linearity, deep entanglement, and emergence, mean that almost anything you do in a complex system will have an unintended consequence. Things that you can't see or detect based on the thing that you change. And if we know that that's true, then maybe we need to start thinking differently about our role in implementing change or enabling change to happen in the health system. If we start to add, which is a sort of a modern focus on fast, verifiable results, then often we can engender multiple small changes that have a localized positive effect, but actually cause secondary effects that may not be so positive or useful in the system. And then someone else will go in and fix those problems, and then they will have a unintended consequence somewhere else in the system. And we can set up what we think of as a sort of a quality improvement whack-a-mole. Every time we solve a problem, another one seems to emerge somewhere else. Okay, and we kind of see that. We start with the key is it forces this thinking forces us to start with a linear plan and then be confronted by the complexity of the system. So it forces us to consider a hypothesis and then watch it crash into the actual reality of the situation. Okay, and as we continue to do that, it gets exhausting and it's expensive and it takes a lot of energy and a lot of resources to maintain that system. So we start to think about it in a different way. Okay, so the next point I want to bring out is this idea of authenticity. If I can show you that the system is complex, and I can show you that some of the methods and ways of working that we use today are best suited to an audit system, then by definition, we are taking an inauthentic view to how we operate in terms of health, safety, and quality. Okay. The example that I might use is if I have a sore back. I've been to the gym a fair bit, and I'm starting to get a backache. Now, I have some options about going to see perhaps a homeopath or a chiropractor. I could go and see an engineer, like a mechanical engineer, or a veterinary surgeon, or a physio. And I would say to you, some of those options are authentic responses or could provide an authentic response to my back pain, and some might not. And it starts to become obvious to us that that is the case. Well, it's obvious to me as a practitioner of anthro-complexity that some of the interventions we use in the complex health system are inauthentic. Okay, so I want to bring out sort of three kind of rules or rules of thumb that you might want to consider. And the first one is, if you are intervening in a complex system, then stop doing it if you don't understand complexity. It's like an engineer who's designing a bridge and doesn't understand physics. If you know that this is a problem of physical nature and you don't understand physics, either find someone that does or stop doing what you're doing until you can learn it. In the last 20 years, there have been massive leaps forward in terms of our ability to understand and provide effect in complex systems. Okay, it takes a long time for the system to catch up, for the practitioners in the system to catch up. There's a lot of inertia where people resist having their worldview challenged. There's a lot of inertia to saying, actually, the things I've been doing in the past, they might have worked in the past, or they might have been the best tools in my toolbox in the past, but there are better tools now. Okay, so my first point there is just push pause and go back and actually contextualize. If this is a complex issue and I haven't got the tools I need to manage complexity, maybe I need to go and find those. The second point is the only way to act or understand, a complex system is to act in it. Yeah. So the only way to know if you and I are going to be friends is for us to go out and have a coffee and a chat and maybe interact a little bit. I can't write my resume and you write your resume and work out if we're going to be mates. It doesn't work like that. Human interactions are a complex relationship. Okay. So if you are, I'm going to bring this point out again and again, is if you are making decisions that impact a complex system and you are not interacting with it, then you must devolve that decision to someone who is. Otherwise, you are taking an inauthentic, regardless of your intent or how clever you are or how skilled you are or how many times you've done it before, it's a fundamentally flawed assumption that you understand enough about the system to guarantee or be confident in providing a positive result. The unintended consequences are likely to be more than you can manage. And the third point is, if you take action in a complex system and you know that unintended consequences are almost certain, then you are morally obliged to detect and respond to those, because they could be the things that push us into chaos. And the world is full of some really horrible examples of health policies that have led to extremely poor outcomes because people have either outsourced or are blinded to the consequences of those. Yeah, so blanket policy changes without a detection mechanism, they might work, but they are inherently dangerous because you cannot see into those dark spaces where bad things might be occurring. So in my view, particularly in the health system where the consequences are often more than we can handle, like we're morally obliged to do that. Okay, so what we've got, I guess, is a system where the tools that we use are effectively, let's say, developed for a sort of a 1980s manufacturing paradigm. So large Western democracies who are manufacturing tools like Toyota cars and Motorola phones give us Lean Six Sigma, PDSA, etc., etc. Those are linear tools that manage the variability when you want the output in an ordered system to be consistent. So my Toyota will look like your Toyota if we both drive Corollas. Back in the day when we had a Motorola phone, I'm not sure who does anymore, my phone was interchangeable with your phone. Okay, so they're designed for systems that are repeatable, designed for systems where you want to manage variance. So I would ask you the question, are two patients the same? Are two medical teams the same? Are two GP offices the same? Are two surgical theatres, they might have the same equipment, but are the teams the same? Are the surgeons the same? Are the nursing staff the same? We have a system that is dynamic and non-repeatable, and oftentimes we're using tools that are designed for systems that are linear and repeatable. And this is this challenge of authenticity. All right, so what do you do? Okay, the first thing that we do is we start with complexity. So if we start with linear tools and then crash into complexity, it's going to be massively inefficient. So start by saying, I think the system's complex, and let's maybe look for some parts that are ordered and we can use our tools there. And so we start to think about different tools and techniques that we might use. And these are tools and techniques that we call sense making. How do you harness the naturally occurring narrative in your organization to see themes in it that we can use to prompt the system to move to a better place? One of the rules here is start where the system is rather than describing utopia and then trying to force the system to move towards it. Manage the reality of today rather than the ideology of tomorrow is another way of saying that. Okay. And this is where, like we really crash into, frankly, the Six Sigma view, where Six Sigma is a utopia and we're trying to get there. It's fundamentally inauthentic. We have tools like, naturalized sense making, weak signal detection, nil hypothesis, abductive research, so moving away from empiricism at this point, constraint mapping. What are the dark constraints that prevent organizations changing? I'll give you an example. I've probably got enough time. I'll give you a quick example in terms of sense making. Every organization on this call will have words to the effect of, people are our most important asset. People are our most important, thing. He tangata. We've got this idea. And I say, actually, that might be true, or it might not be true. So maybe we could go out and ask a question about people. This is sense making, i.e. making sense of the world so we can act in it, to use Dave Snowden's phrase. And we say to them, describe a time in your recent working history where that principle was upheld. And describe a time in your recent working history where that principle was under threat. We could all do that, right? Describe a situation where actually it didn't look like people were our most important asset. Describe a situation where it was. And then we put those narrative in front of the leaders and the managers and the decision makers and the people themselves. And we say, how do we act in a way where we get more stories like this? And how do we act in a way where we get less stories like that? And that is an authentic response to the complexity of what it's like to work here. And now by being in touch with the narrative, people know how to take direct action in respect to what they're hearing and seeing in the workplace. We have disintermediated our situation so the people in the complex space are empowered to take action. Which brings me to the second point, and that is distributed leadership. And I know, I hear the phrase single point accountability, right? Single point accountability without the power to allocate resources is massively frustrating. It's like saying, I will blame you, but I will not give you the tools you need to change your situation. Now add a human resources mindset that is what I would say atomistic, i.e. we're treating the individual as a unit of decision making. We know in complexity, value is created by interactions, not by individuals themselves. So by saying you are locked into a rigid system, you do not have the tools to change it, but I'm going to blame my observation of that system on your mindset or your behavior is massively disrespectful and disempowering to most people. So distributed leadership is about giving people both the psychological safety to express themselves in the system and the ability to take effect to change that. Okay, we are relaxing the constraints in order to allow the people who are interacting with the system to make decisions to move in a better direction. And that is very, very hard in a system where budgets are pushed up and accountability is pushed down. And the third point is this idea of team science. We know that value is created between the agents in the system here, not by the agents in the system here. It's very often that any outcome in a health sector is due to the actions of one individual doing one thing. It's a group of people working together. And what we want to do is move away from the sort of atomistic view and actually teach people how to operate as a team, right? we have this very individual focus in terms of things like leadership development and personal development. And I don't often see authentic methods in terms of teamwork. There's two angles here that I want to talk to you about. There's two sort of areas of the world where we should or could learn from. The first is actually the military. The military are very, very good at the tools and techniques around teamwork, because if they get them wrong, teams of people die. They have techniques we call red teaming, team science, etc. The second thing that we've got here in New Zealand is we have a culture, the Maori and Pacifica communities. They understand things like intergenerational well-being. They understand the power of whānau and iwi in order to get and support the vulnerable amongst us. Okay, what I see in this world, and I'll be a bit sort of blunt here. A lot of the people on this call are former sort of NHS people. There's nothing inherently wrong with that. Okay, but I know from having lived and worked in the UK that there is no cultural equivalent of the Maori and Pacifica communities in the UK. So rather than taking the view that we need to accommodate these communities within the linear, rigid, atomistic and deterministic system that we have, maybe we could relax our constraints and shift our system to a place where we know that we have people who are far more attuned to the idea of teamwork and whānau than we will ever be. People who don't look like me, frankly, and think like you. Okay, and that's going to mean, again, a fundamental shift in the way that we think. So that's enough about sort of my kind of lecture. So I'll ask you the question, should we follow Toyota? Should we continue with these methods that are invented by the large manufacturing agencies in North America? And actually the answer to that, just very quickly, is yes. I was going to show you something. I'll share my screen for a minute. This is Toyota. This is what Toyota are now calling their flow system. For years and years, Toyota, the paradigm with which they ran their vast global organization was based on the Toyota Production System, or TPS. And that was about lean systems thinking, this sort of Six Sigma stuff, a lot of the Japanese management practices that you might have, and I certainly did learn at university. They then had the continuous improvement, respect for people kind of mindset. But even Toyota have realized that the complexity of the modern automotive industry is now clashing into changing socio-economic conditions, changing expectations. So my colleagues in the US, these are people who are now my business partners, formed a consortium who have worked with Toyota to move them to what they call a flow system. And you'll see at the top there, it's got customer first value delivery. You could exchange that for patient first value delivery. And the three cornerstones, or strands of DNA, they call it, that they use, turns out are complexity thinking. So they talk about Kinevin, they talk about complex adaptive systems. They too lean very heavily on the work of Dave Snowden and his network. They talk about distributed leadership, psychological safety, active listening. And there's a number of other tools in there that you may not have heard of. Wardley maps, for instance. Collaboration, bias towards action. And the third one is, of course, team science. They come at this very much from a North American, military bent. And you'll see here, we've got, red teaming, human-centered design, which I know a few people on this call are pretty good at, situational awareness, shared mental models, et cetera, et cetera. So I can put a link to that in the, so I'll just stop sharing. I'll put a link to that in the chat. But that's really enough from me. I'd be quite interested in hearing from you guys in terms of your perspective, if we've got any questions or anything you want to talk about.
There are a couple of questions in the chat, Steve. I'll read them out for everyone.
Okay.
From Catherine, what about when it's important to reduce error in theatre? Would it use a linear system then?
The answer to that is I don't know. My problem-solving methodology would be to say, which parts of this can we control? So if we've got absolute control over the inputs, the process, and the outputs, then you would use your linear methodology. It's an authentic response. If the system could generate, or is complex by its nature, multiple agents acting in ways that we can't fully understand, then maybe we need to start thinking about multiple safe to fail experiments. What can we change? How can we monitor the output or the outcome of that change? How do we amplify success? How do we learn from failure? And then we might want to try multiple experiments in parallel, and then we learn about the system by acting in it. Yeah, if we've got an expert, someone we can ring and say, hey, what do we do here? And they go, actually, we had that problem 2 years ago and we did that. We bought this machine, we changed this process, and we're back to complicated. We've got an expert that can help us. If we can't find an expert, or we don't really know what's moved forward, it's unprecedented, then we go, okay, what does safe to fail experimentation look like here? And then we amplify success, we learn from failure. It's a good question. So there's no one answer. It's context first. What is the context of the system we're in? And then you apply an authentic methodology to that context.
Thanks, Steve. So Andy just wanted to capture the 3 rules of thumb that you spoke about, and he also suggested that could be sent after as well. If
yeah, I do have an annoying habit of just sort of scribbling stuff on my iPad and then blurting it out on screen. So if you guys want a set of notes based on what I've just talked about, I'll send those through. I haven't. Yeah, I mean, based on, and maybe we could answer some of those questions in those notes as well. So I'll get those written up, made a little bit more professional, and then I'll send them through to you guys for distribution. Assuming you guys want them. If you don't, I won't go through that.
Yeah, no, that sounds great. Thank you, Steve. I'm sure it'll be appreciated. Yes, and there's heaps of yes pleases coming through in the chat.
Okay.
So Mary asks, is collaboration, teamwork with Māori and Pacifica currently in practice? And I'm not sure if that's a question to Steve or to the audience. I'm not sure, but
I can't answer that. I guess you guys could.
Yeah, I think, yeah.
I'll make a point. Can I make a point about that?
Yeah.
I heard on the radio the other day, a Pacifica Organisation, and you guys might have heard of this philosophy, is any door is the right door. You guys familiar with that? Yeah. And what that speaks to is actually we need a dynamic system that self-organizes around the needs of the individual. So they can come into the system anywhere they like, and then we will coalesce and help them through. And that's in a distinct contrast to the more linear approach where we say we're going to design a system and then expect you to learn how to navigate it. One is a systems first approach, and this one is a customer centric or individual first approach. And I think, you know, learning from that and then maybe trying to apply that in more rigid health circumstances would be very, very useful. And the way to do it is engage with the people who are facing that problem, who are in learning and interacting with that system, which would be that Pacifica Organisation. I don't know who it is actually. If you guys do, I'd love to make contact.
Got a question here from Fiona. Currently, there's a huge problem in health staff shortages. Brainstorming training and retraining has us going round in circles. Increased pay may lead to staff choosing to work part-time. Funding study may be a way of training Australia's workforce at New Zealand's expense, etc. Good example of a complex problem, question mark.
It's an exceptionally good example. I just missed a call from the CEO of a construction company, and one of their biggest problems is there are massive staff shortages. The Australians are stealing our people. It's almost word for word. So this is a systemic issue. It's not a health issue. And my advice to them is, firstly, it's not a problem to be solved. No one's going to say, actually, I'm a genius. I can come in and solve this for you. Rather, what we think about is what parts of the system can we change? And one of the things that I'm starting to see, or I kind of like the sound of, is how many roles and how much work or effort that we put in do we do where you don't need to have a whole lot of expertise or, let's say, training. And then how do we quickly bring people who are intelligent, curious, and hardworking from other domains in to fill some of these gaps? And that allows trained medical people to do medical stuff rather than maybe admin stuff. Okay, how do we augment some of our processes with technology to make them more fluid, faster, etc.? How do we get good at rapidly bringing people through our training systems? That's all we can do. How do we get really good at bringing people who maybe don't share our language or cultural background into our system in a way that they can provide effect? That's all we can do. We can manage the tension, but we're not going to solve the problem.
Great. Thank you very much, Steve. That's been just fascinating, really interesting, and I know everyone's enjoyed it. And there's some comments to that effect in the chat, but I will hand back to Gillian to continue with the rest of the session, but thank you very much.
Thank you.
Steve, it is up to me to say thanks on behalf of us all. Absolutely fascinating. Lots of parallels. I think you'll see from the chat, which we'll share with you, that people find that given the situation we're in, there are lots of clues in here to do that. So again, thanks, and we will move on to our next presentation. So we've got the next presentation is HOP Squad, cross-service collaboration to improve complex discharge planning for at-risk elderly patients. The two people that are presenting today are Cindy Blackwell, who's an improvement advisor, and Julie Yap, clinical nurse specialist in gerontology from County's Manukau Hospital, and Charlene Bingham, the service manager. I actually think that Cindy will tell us that it's only Cindy and Julie here today, and Charlene hasn't been able to come to us. But so over to you, Cindy, who can, and you and Julie can do further introductions if you would like of yourselves. Thank you.
So I'll just quickly start with a bit of introduction and background. That Middlemore Hospital is a 900-bed hospital serving a diverse and multi-ethnic community with many living in high socioeconomic deprivation. This project is within our general medicine department, and it focused on patients who were 65 years and over who had complex discharge planning needs. As a way of background, the HOP Squad project fits within our much broader Every Hour Counts program, which aims to improve acute patient flow right from the front door through to inpatient to discharge and out into the community. And the HOP Squad was a change idea that came about from a project that we were working on to standardise our NASC processes. And we realised that as it's a cross-services change idea, we needed to establish it as its own separate project. During our earlier work, we mapped the discharge planning process with clinicians from our Gen Med wards, and this highlighted that discharge planning typically doesn't start until a patient is medically cleared for discharge, and that can be less of a problem and create less delays when everything's within the control of the ward to organise, but when it's complex, activities tend to happen in a number of sequential steps, which can then lead to delays. This is especially the case for our most frail and elderly patients who have come from home and are now thought to require either rest home or private hospital level of care. So when there's a question about discharge destination, is it home with increased supports or placement into an aged residential care facility, there are a number of assessments that are needed. And our data showed that these assessments took 5 days, and these delays to discharge put our patients at risk of deconditioning and hospital-acquired infections. So we're keen to support best practice discharge planning, which actually starts when a patient is admitted to the hospital. So our aim statement for our project is to reduce the time taken from first discharge referral to final assessment. So Gen Med patients referred to the HOP Squad, which is Health of Older People Squad, from a median of 5 days to 4 days by the 30th of November 21. As the HOP Squad developed, we collected data on other important processes and outcomes too, and we'll share those at the end of our presentation. But what we realised is that complex discharge planning is complex because there are multiple services who are involved. And when there are services outside of the ward, referrals are required, which in turn need to be triaged and allocated. So our project sought to improve the timeliness and the coordination of these activities, to increase information sharing, both between the clinicians and the patients in whānau, and also between all those different clinicians who are involved in the discharge assessment and planning process. And our ward clinicians said actually they weren't too confident with complex discharge planning and wanted to increase their knowledge and confidence, including the appropriate pathways into the community. So in a nutshell, the HOP Squad is designed to ensure that our frail and elderly patients on the DenMed wards experience the same level of discharge planning as those on our specialist HOP wards, the acute care for the elderly.
HOP Squad is made up of clinicians who are expert in elderly and frail patient care. The aim is bringing together clinicians from HOP Squad and the ward team to work together in partnership to discuss discharge planning for the patient to go home safely. This gives opportunity to the ward team to stop their busyness, to sit down, to focus on elderly patients with complex issues, and to exchange ideas with other clinicians. The purpose is to support and enable the ward team to explore options to discharge patients home safely with wraparound community services. For example, with elderly, the acute setting is not the best place to address frailty. Some patients are discharged with follow-up by the community geriatric service for comprehensive geriatric assessment. Indirectly, HOP Squad is empowering ward team in upskilling discharge planning for other patients. As we progress, some clinicians from various services were interested in joining, so we tested their participation. Some stayed and others left. We find community health services, hospital in the home, and complex nurse management are useful for continuation of care in the community for chronic management. This potentially prevents avoidable hospital admission.
So we used the model for improvement methodology for our project, and we drew on important patient experience that was gathered during our understand and diagnose phase, where we interviewed a large number of patients about the experience of discharge planning in general, and also a smaller group of patients in their whānau who had chosen to move into age residential care for the first time. We ran lots of PDSA cycles on to develop all aspects of the HOP Squad process, including the criteria for referral to the HOP Squad, the HOP Squad membership, the huddle logistics, the roles, responsibilities, how we met in person or Zoom, the meeting frequency, the processes as to how patients were identified and what information needed to be brought to the huddle. We started on one ward where we ran all of these tests of change and are taking a staged approach to spread.
Why the project is successful? Clinicians are committed to working through the testing process. We appreciated the spirit of experimentation. We continued to develop new ideas to test and retest until we could see the impact of our efforts. We have committed project leadership and sponsorship, which has built buy-in. We gathered and analyzed data to show the impact of changes. As traction was gained, other services saw the value and joined the HOP Squad. With successes, there are also challenges. For example, the first ward was open to HOP Squad's concept. Clinicians from both teams were new to the project and are committed to work through the PDSA cycles. The second ward is known to be good with discharge planning due to a very experienced and proactive social worker. Such as they couldn't see any added value. The first meeting was via Zoom. The audio was poor quality. This factor make it hard to build a rapport and lead to poor engagement. It was difficult to build a workable partnership, even when we had the opportunity to meet face-to-face. The third ward was the ward that we had been working with to collect comparative data, and they were excited to join the HOP Squad. In addition, the allied team members were previously worked in geriatric wards. They understand the complexity of discharging elderly patients home safely. They foresee patients' functional baseline and social background affecting a patient's discharge destination. This enables early conversation with patient and their family on options. Where is home from hospital? Overall, most clinicians embrace the opportunity and the knowledge they gained. A few couldn't see the value. Then COVID came. No face-to-face meeting. Zoom is not the best way to build workable partnership, although it worked well once we had a good rapport. Hopscotch stopped during lockdown and restarted in January. 2 of our wards now are allocated as COVID wards. Hopscotch stopped again. Data collection can be challenging. There were no pre-Hopscotch data available in the system for pre and post comparison. It was time-consuming to gather the comparative data from another ward from scratch.
So throughout the project, we collected a lot of data, including identifying and tracking discharge activities for comparative patients on one of our other GenMed wards. When we look at the data relating to our aim statement, it showed that the Hopscotch ward was able to achieve our aim to reduce the time taken from first referral to final assessment from 5 to 4 days. And this is compared to 5 and 6 days on the other GenMed wards. Length of stay is often used as an indicator of patient flow. And while it's a blunt tool, we monitored length of stay for Hopscotch and comparative patients. The mean length of stay for Hopscotch patients was 11.4 days compared to 15.5 days for the comparative patients. Hopscotch patients were also more likely to be referred to a community service. And when we looked at the type of referrals that were made, we saw that Hopscotch patients were referred to a much broader range of services. This indicated that having the community input with knowing what services were out there helped the ward clinicians to link into those for the patients. Feedback from our ward clinicians told us that their knowledge and confidence did indeed increase after participating in the huddles over time. And on average, they went from feeling moderately confident to feeling highly confident in complex discharge planning, which is what we really wanted. We want to be able to make the Hopscotch redundant as much as possible. Community clinicians told us that they appreciated hearing about the patient's stay, and being involved in the discharge planning enables a smoother transition into the community. So our next steps are with COVID. We will continue to face challenges and changes every day. The good thing is that the ward clinicians continue to see the value of the contribution of the Hopscotch, and even when the ward workload necessitates that we have to, or COVID, put a halt to huddles, they still continue to call the Hopscotch members as appropriate when they're feeling stuck or need advice. In time, we hope to continue the spread of the Hopscotch to additional wards and further increase the knowledge and confidence of all clinicians over our GenMed wards. And I just wondered, would it be helpful just to finish with a real quick patient story as to the impact of the Hopscotch? So we had a patient who had had 4 admissions in the previous 12 months, including a 2-month stay in the stroke rehab ward. And they came in to our Hopscotch ward with exacerbated COPD, but the patient really her goal was to go home. Placement had been discussed previously, but she and her family really wanted to be able to be discharged home. So she was, with additional supports, including a visit from our community geri service, where they did a great assessment with the patient in the home, was able to identify further needs to support her to stay safely at home. And she didn't have a readmission within the time frame that we measure. She did have one a little bit later, but her condition wasn't so acute that she needed to be admitted into an acute bed. Instead, she was able to be admitted into hospital in the home, which would have been a much better experience than another stay in hospital. So that's the sort of thing of what our Hopscotch's trying to achieve.
Fantastic. Thank you very much, Cindy and Julie, for that great presentation. There has been one comment and one question in the chat so far. We've just got a couple of minutes. The comment from Sally: it will be interesting to learn if the current inter-RI acute care pilots show discharge planning improvements. Thank you for your presentation. And from Jackie Harris: what are the actions you have implemented to ensure that the work done is continued?
That's a good question. It sort of has, on our Hopscotch wards, it's become quite business as usual, but we still have work to do in terms of going to the other wards and spreading it.
Yes, that sort of came across in your presentation as well. And you commented in your presentation that other services saw some of the benefits that you gained and joined, which is sort of an example really of that emergent spread. I just wonder if you would like to share some insights around that, how you saw that occurring, anything that you did that prompted that.
Yeah, so we had great interest. Some of the ones that, the real successful was around the complex case management and hospital in the home. When they heard about it, they were keen to be involved. And that was really valuable, and they've added a great contribution and continue to participate in that. We also had people, because the Hop Squad was gaining a reputation for really connecting with the ward clinicians, and there were shared models of care was something that they were quite keen to see whether that could be something that could be sort of leveraged into the Hop Squad. And we tested that for a short time, but it didn't, and Amber Care as well. But while those are really valuable models, the Hop Squad itself and the Hop Squad huddles wasn't necessarily the best place to be, because they're a 30-minute, short, sharp huddle talking about quite a number of patients at a time, that it wasn't quite the right forum for those models. Yeah.
Thank you very much. That's fantastic. I'll hand back to Gillian to continue. Great job keeping to time, I have to say.
Thank you very much. Thank you, Jane, for being our Yoda today and keeping an eye on the chat and doing that. I just really want to say thank you to, first of all the speakers. It's been really, really interesting content. I'm sure we've stimulated people to think, particularly Steve's work around Carnarvon, and will, as Steve said, put it into your Google, and Google will bring you heaps and heaps of interesting articles and further information about that. Great. I just want to remind you that we've got 2 more of these sessions on the 10th and the 24th of March, same time, same place. So, and thank you all for attending. We wouldn't be able to do this without you. So thank you. And over to Jane to a closing karakia. Thank you, Jane.
Thank you, Gillian. E karakia whakamutunga. Kua mutu a tātou mahi. Ka tae te wā, mo te whakairi te kiti. I te kiti kōrero. I te kiti whakaro. Hei tiki atu anō mā tātou. Tauwhirotia mai mātou katoa. O mātou hoa, o mātou whānau. Ai au ki te aorangi, hui e, tai ki e. Kia ora, everyone. Thank you.